Kostas.
Thank you very much. And just waiting for my presentation to show up. Okay, thank you. And thank you, Dimitris and Kostas, for organizing this session. So I'm going to deliver a very, let's say, initial talk about a new project. The name of the project is BOUNCE, Predicting Effective Adaptation to Breast Cancer to help women to bounce back. So this is a New Horizon project that just the grant agreement has been signed. Our initial goal in the session was, and my personal preference, that a breast oncologist or a psychologist of the consortium would deliver the talk, but they were both unavailable. So instead, I will deliver the talk. I'm a biomedical engineer. So it's, I will try to discuss about the goals and the motivation of this project as much as I can. So basically, the inspiration comes from this, can be kind of summarized in this paper, 2014 paper. And it states that the cancer continuum represents a series of potentially traumatic events. So actually, these events may start even before the diagnosis, because we know that healthy individuals perceive usually great stress even from the idea of a life-threatening disease. The most affected are probably the recently diagnosed patients that need to face dramatic life changes and continue to adopt throughout this treatment, diagnosis, and uncertainty. Even for survivors, that people have the idea that they might feel very lucky and very, very fortunate to be in that portion of cancer patients. Even for survivors, the things are not so ideal as we think, because they have to adjust to the idea of a new normality in their lives. And of course, the threat of a possible relapse is always there. And there is the group of people and patients who face death, and this is probably the most challenging in terms of psychocognitive changes, because these people really need to struggle and to maintain a positive attitude towards life, find a meaning, and so on and so forth. So this paper states, and this was actually the inspiration for this project, that all these different phases have unique characteristics and shared aspects of resilience. And this, what we call resilience, and as I would state later, there is no, let's say, uniform and universally accepted term for that, can be different in different, can have different characteristics and manifests in different ways during lifetime. So why in this project we chose resilience? That had to do, of course, with a call of the European community. But why in cancer patients? The answer is quite straightforward. According to the World Health Organization, the incidence is still rising, and this might come as a surprise because we hear about molecular therapies and classification in breast cancer. Still, the incidence is rising. I mean, we're not fighting the cause of cancer, we're fighting the disease. Oops. Okay. At the same time, although the incidence is rising, the mortality is dropping, and it's reaching now to 90%, and in some cases that we have localized breast cancers, even close to 100%. But the net effect is, of course, a huge increase in the number of people who suffer from breast cancer and women that have survived. And this calls for novel strategies for understanding, predicting, and, of course, increasing resilience of women with breast cancer, mainly to promote the quality of life through personalized interventions. So this project, of course, is targeting that last sentence, to be able to predict and deliver, therefore deliver individualized interventions to women that need them the most. So this is, of course, the main motivation of the project, that it is becoming a major socioeconomic challenge, And of course, we need to have strategies to improve the understanding and the capacity to predict the resilience. And we can consider that this is a stepping stone for empowering patients and promoting efficient recovery through personalized interventions. Of course, a motivation for the project is also the challenge to model resilience. And for doing that, of course, we need to bring together clinical, social sciences, and of course, modelers, mathematicians, computer scientists. And the target is to advance the current knowledge of this dynamic phenomenon that we call resilience, because exactly it is related to the efficient recovery from breast cancer. So we're not only trying to modeling just to predict what will happen, but we know that if we increase with psychological, for example, interventions, the resilience of the patients, this can have a direct effect to the outcome of the disease or the therapy itself. So the main goals of the project is, first of all, to predict resilience trajectories. And we're using the plural tense because we're not only trying to predicting resilience is kind of an abstract term, but this, of course, is connected to a number of lifestyle factors, to a number of factors such as the adaptation of the particular patient to the new reality that the patient is facing. Understand better the dynamics of resilience, because especially in this critical phase of diagnosis and therapy, this can change dramatically, and the interplay between physiological and clinical factors. So this is well known, but it's not really understood. So we know that one trajectory can influence the other, but we don't know exactly which specific parameters are related for the individual person. And of course, there is nothing good in predicting unless you can do something about it, and this is actually what the project wants to deliver, to be able to identify the patients that are more at risk of not being resilient. And as far as I understood from psychologists, resilience is a kind of an effort to bring positive psychology into names. And of course, to help people through individualized interventions to have a better quality of life, keep their jobs, keep their lifestyle as before, as much as possible. To do that, strategically is important to measure at a very frequent time points biological, clinical, lifestyle, and psychosocial parameters to be able to predict. And to do that, we will follow a modeling approach, both, let's say, theoretical, trans-theoretical approach from literature, and, of course, data-driven approach from all these measurements, and deploy a prospective multi-center clinical pilot at 4 major oncology centers, with, of course, the prerequisite that they deal with a large number of breast cancer patients, and that they include psycho-oncology in their clinical routine. So this was the prerequisite for including these partners from Italy, in Milano, the European Institute of Oncology. In Finland is the University Hospital at Helsinki. And Israel, and in Portugal, Israel is the Hebrew University, and in Portugal is the Champalimau Cancer Center. So we estimate, because of course there will be a number of eligibility criteria, that the project will engage 660 women in order to assess their clinical, psychosocial, and lifestyle characteristics over time, and well-being, of course, will be an endpoint, and functionality and illness progression. So the advanced computational tools that we hope to develop in this project will validate indices of the patient's capacity to bounce back during the highly stressful treatment and recovery period, and I will come back to that in the clinical design. And the project will incorporate dynamic in silico predictive modeling approaches And of course, this will need to be coupled somehow to a decision support system, because there is no point to predict something that changes all the time without having a very discrete way of describing it and giving the degree of severity when it comes to non-resilient patients. The key technological aspects and challenges of the project will be, first of all, the development of an in silico resilience trajectory predictor, and this will be part of the decision support system. And we can see that this in silico resilience trajectory predictor will try to bring two things together. One will be to measurements from all the lifestyle, nutrition, socioeconomic and psychological factors, and the other will be cancer multiscale models of the disease. So initially, when we were discussing the project, we thought that and we made a lot of progress to that direction over the last 10 years, especially our group in participating in projects of trying to predict cancer evolution. So if we can predict the evolution of certain types of cancer, this would need to understand how this could affect the changes in the resilience of the patients, and how we can use that in advantage in terms of delivering at patients who we know that have will have a worse prognosis, to deliver them early psychological interventions. Of course, as I said before, from the engineering perspective, we need to also have a discrete classifier, and this will be based, of course, on the multidimensional data that we will be recording. And to this end, we will have the collaboration of a pioneer company from Finland that it's called Nuna. And what Nuna does, and you can see here their web page, is offering a smart cloud service that it's trying to link patient-reported outcomes to their clinic, to the clinics. So basically, they are let's say, the mediator that they ensure that their clinician, the breast cancer patient, will take into consideration all the patient-reported outcomes that the patient is kind of inputting in their mobile device each day. So this classifier, and here is shown in a very simplistic diagram, is trying to take all this existing knowledge and this new knowledge that will be produced in the project, and try to classify this multidimensional vector of values coming from a heterogeneous data pool into two populations, the resilient and non-resilient, and therefore classifying the status as green or red. This is a very typical kind of color coding in these applications, because if the patient also has some view, we don't know what will happen in that to this end, but the clinician prefer this color coding. For example, red can be the less resilient patients, and green the patients that are more likely to be resilient in the next, let's say, 6 months. And of course, we are very realistic. We know that there's going to be a percentage that would be impossible to classify, and we will have an uncertainty. Another key technological aspect, of course, is the decision support module. That this module will follow up the trajectory prediction and the classifier, and will probably recommend to the, first of all, to the oncologist and to the clinic to provide the specific patient with psychological intervention if this is needed very early. And of course, the goal would be to improve the quality of life in the cancer continuum. We know that it's already been reported in the literature that these resilience trajectories are not deterministic. You know, they can change, they can be modified, and of course, there is a lot of evidence that psychological interventions can be one of these transformative experiences for the patient. But of course, we also know that lifestyle changes are also very important, and they can influence not only the quality of life, but also the outcome of the disease or a specific therapy. And we believe that the empowering component of this project would be that the patients themselves understand this better, that their psychological status, their lifestyle habits, and the fact that they are kind of receiving psychological support may have an effect not only in their mood, everyday mood, but also in the outcome of the disease. The clinical studies design, I will not say much, but we're going to have 4 oncology centers that follow this kind of holistic approach in treatment and include, let's say, psycho-oncology components in their routines. As we said, one will be the European Institute of Oncology at Milan, and it would be nice to stress out that in Milano they have an academic psycho-oncology unit within the oncology department, and this is quite remarkable. And University of Helsinki, of course, has a large experience in these psychocognitive aspects of breast cancer disease. Hebrew University and the Champalimaud Foundation as well will contribute to this patient pool and will follow similar, or if not exactly the same protocols throughout the studies. And the aim would be, of course, to identify these interacting trajectories of environmental, lifestyle, clinical, biological, and psychosocial factors. Critical to the clinical design is a planned, after the baseline, of course, a planned 18-month follow-up window to cover up this crucial post-diagnosis period of the patient, where several changes will take place at, of course, the biological and the cognitive and emotional level. The clinical design will study multiple indices of resilience to ensure that all theoretically relevant aspects are taken into consideration, because, as we said before, there is not a unified, let's say, definition and a widely accepted term of resilience. And in the final computational model, of course, there will be a moderation in the weight of resilience indices according to the endpoints, which, of course, will be clinical relapse, well-being, and the functionality of the patient. And we hope that this will ensure that both theoretical, for example, the construct of the trans-theoretical model of resilience and clinical validity of resilience measures and models will take place in the project. The clinical study design is mainly divided into periods of 6 months after the baseline, and at the end, the initial measurements will be used to build the models, the last measurements to validate models, and the outcomes, of course, will be well-being, functionality in family, social work, and clinical outcome, of course, is very important, because we hope that we will find a lot of evidence connecting the outcome with all the early interventions and the psychological status, lifestyle, etc. In terms of reference architecture from, of course, the engineering side, we have, of course, the challenges of the semantic tier of the project, the semantic integration. Especially in this case, we have a lot of data, heterogeneous data and variables that we need to bring together, coming from all these different aspects of the patient's life. And we need to integrate them semantically and be able to link them, of course, with all the models and all the technologies that we're going to develop, which is not a trivial task, as we know from previous projects. And, of course, the application tier will have all the developments concerning the models, the mathematical and statistical modeling, and the validation. And, of course, this will all relate to the implementation of this technology and the validation in the clinical sites. And the last two slides will basically, I will basically say what is very interesting, of course, for the psychologist, is to explore, of course, the resilience, the nature of resilience. We know that it's linked to the patient's capacity to successfully adapt to this life-threatening disease, but there is not a unified definition, so Bounce will adapt, and this will be the work of the psychologists, a dynamic, of course, trans-theoretical model of resilience in the lack of a universally accepted definition. Of course, being a dynamic phenomenon that is shaped by a host of physiological and biological processes, we need to understand what is the interplay of the biological and the psychological trajectories that affect resilience. And in reality, resilience is more likely to exist in a continuum, being a dynamic phenomenon, and can be manifest itself differently into multiple domains of life. For example, as we state here, an individual may be adapting very well to stress in the workplace or in the academic environment, and at the same time may fail to adapt in their personal lives or their relationships. And this is well known also from our personal experiences. And another key concept, of course, is the adaptation to illness, and we have psychologists in the consortium that they work on that for a number of years. And we have, of course, in the project the testable assumption that the resilience trajectory is in close relation to the medical and psychosocial trajectories. And here we, from the psychological science perspective, they are very interested to study the dependence of these two trajectories. And not only to see that, to understand the transactions between the psychosocial and the clinical dimension, but to examine their close relationship and understand which variables, exactly which variables from these two trajectories, one being the psychocognitive and other the clinical, affect each other. And this is, as we say, it's not about only predicting, it's about understanding, and for the psychologists, this is very interesting to understand the interrelationships, interplay between biology, clinical observations, and psychocognitive measurements. And of course, we're not working, we're not doing this without any prior knowledge. We know that early stages of breast cancers come together with depression, and of course, the numbers are different. Some estimate that it's 15 to 20%, and some others report that almost 50% in the first years have anxiety or even depression signs. What would be the most, of course, scientifically challenging part of the project is to see whether it can be understood, as we said before, biological mechanisms that correlate the changes in the psychocognitive profile of a patient with the underlying biology. For example, stressors, external stressors may, for example, trigger dormant cells in a tumor, and we may have relapse. This is an assumption that many people accept, but it's very difficult to find evidence. So in Bounce, except of course the ultimate goal, which is to help individually through a personalized medicine framework, the patient to have a better quality of life. Understanding the biological interactions at this level with the psychocognitive interactions is, of course, a major challenge, and we hope that there will be some interesting results in this project. So on behalf of the consortium, I would like to thank you, and just make a note that this is let's say, equally spaced. There's an equal space and equally weight in the consortium between clinical, ICT, modeling, and social scientists and psycho-oncology experts. So we hope that it's going to be a very exciting project, and I hope that colleagues from the project will report very interesting results in the next years. So thank you very much for your attention.